Dr. Ashok Seth, he is a Padma Shri and Padma Bhushan awardee, and he is the chairman of Fortis Scott Heart Institute, New Delhi. And why this subject interests us is because the first patient, who was an Italian doctor admitted in Jaipur, became all right 14 days, and after that he died of a cardiac arrest because of a acute heart attack. We have people in India, 7% of the people who died in India are less than 40 years of age. We don't know how many of them were cardiac in origin. We know that this causes myocarditis. This has something similar to a viral which causes myocarditis. We know that if we give hydroxychloroquine and azithromycin together, there is a cardiac risk. We know that it causes highest mortality in patients with coronary artery disease. And we know that people will continue to have interventions during COVID times. So we need to take precautions. We also have experience from the Wockhardt Hospital, which shows that every patient admitted in the hospital, irrespective whichever department, is COVID positive, unless proved otherwise. Because in yesterday's the incidents where the Wockhardt Hospital in Mumbai was closed, a patient was admitted in cardiology ward on 8th day, developed cough, and then it was found to be COVID positive. Nobody suspected him to be COVID. So COVID can be there in anywhere, in every cardiology practice. Let's listen to Dr. Ashok Seth. This is live in MedTalks, and this is also live in Facebook.
Good. Thank you very much. Thank you very much, Dr. Agarwal. Let me congratulate you on organizing such an important symposium by webcast. And I understand that it'll go to 8 o'clock. I would like to be sitting here most of the time, learning from this great speakers that you have on the forum today. I must say this is a fresh start for the nation as far as online teaching and exchange of ideas and exchange of knowledge is concerned. To start it all, let me just say that nobody is any wiser about this novel coronavirus. Over these last 3 months, I would say that everybody has been gaining from the experiences of firstly China, and then secondly some of the Asian countries like Singapore and Korea, and then of course now that it's affected Europe and United States in a big way. Again, experiences, policies, documentation, practices, and the problems they've faced is what is teaching us in India, where we are still at the low end of the curve, should we say. Until recently, we've been looking fairly okay till the fresh cluster from Nizamuddin happened. And let's see what the future holds for us. So there is still a lot of knowledge to be gained about COVID disease as well as heart, I must tell you. Let's see what we've learned in the last 3 months and what we learned from the experiences of the other SARS viruses in the past. So we understand that as of today, we are standing at close to 4,300 cases, which may have increased by 100 over the few hours the slide got prepared, and with more than 100 deaths. Look at the world coming close to 14 lakh with 75,000 deaths in 209 countries. This is the most vicious disease process, a pandemic which has ever happened. I won't bore you with the figures because these keep coming day in and day out, bugging us all and filling us all in, creating despair and distress many a times. But when you just compare it to SARS, which was a frightening disease in 2002, the number of cases were only 8,000. It was just a bigger killer, but it was limited to 29 countries and 916 deaths out of 8,000 or 8,000 plus cases. If you look at the Middle East virus, MERS in 2009, only 2,200 cases in 27 countries and 800 deaths. So those were less infective viruses with high mortality, but now we've got a very infective virus, which is now into 14 lakhs infected, still growing, practically all across the world. And that is a real difference. So it spreads widely. Now we know that patients who have underlying disease conditions are at high risk of complications and death. And these are patients with cardiac disease at high risk of complications from this condition, from COVID-19, from the SARS-CoV-2 virus. And not just that, they have worse lung infestation, worse lung problems, and greater death. Of all the patients who get admitted, and you know in the West, only those patients who get serious are admitted, the rest are being quarantined, either in huge dormitories set up in these convention centers or in football fields or at home. And only those who get serious are admitted to the hospital. Of the patients admitted to the hospital, 40% have cardiovascular or cerebrovascular illness. So we got to understand that either pre-existing cardiac disease or cardiac disease occurring as a part of the COVID-19 disease process is a reality and has to be faced, just like Dr. Agarwal said. And of course, these are due to two reasons. We have interactions with the cardiovascular system. One, just related to the pulmonary being the first target of ACE2 inhibitors, of ACE2 receptors. And ACE2 receptors exist in both lungs as well as the heart. Related to the ACE2 receptor and the organ going for the ACE2 receptor because it uses the ACE2 receptor to get into the cell. This surge of pro-inflammatory cytokines and the systemic inflammatory response, which is the primary target, which is how the lung gets infected. And the systemic response leads to hypertension, tachycardia, arrhythmias, and even sudden cardiac death. Now, when we look at the cardiovascular disease people per se who already have cardiac disease, we also know that they can become really unstable rapidly. And I'll come to that in the next slides. Pre-existing stable situations of cardiac problems can get actually worse. And of course, we know that respiratory system and cardiovascular system are linked closely. When cardiovascular system gets worse, say an LV dysfunction who was stable, starts going into heart failure and then pulmonary edema, is bound to have worse pulmonary outcomes with ARDS happening to the lungs. If ARDS happens, again, the LV dysfunction progresses to a shock state, and we have a conundrum of a combination of cardiorespiratory failure as a whole. So decreased cardiac reserve, increased myocardial demand, we have a significant comorbidity when cardiac status. And that's very similar to other situations as well. Any primary pulmonary situation or any primary cardiac situation has an effect on a secondary pulmonary or a cardiac situation. So it acts two ways. Now, I think this is a very readable article for those who are interested in cardiovascular consequences. This was just a few days ago, came out on the 27th of March in JAMA, and potential effects of coronavirus on the cardiovascular system. And it's reviewed most of the available literature, which mainly comes from China at the moment, with spurts now coming from Europe, should we say. And this figure actually relates how the cardiovascular system affected. The viral infection causes direct vascular infection. It actually causes inflammation of the vessel, and that certainly leads to cellular inflammation, which may lead to plaque rupture inside coronary arteries on a pre-existing plaque, leading to an increased myocardial infarction risk. There's also increased hypercoagulability, therefore thrombosis, again leading to plaque ruptures and again leading to thrombus formation and acute MI. There's sympathetic stimulation causing tachycardia, increased myocardial oxygen demand, leading to increased myocardial infarction or both STEMIs and non-STEMIs. Of course, there's acute respiratory distress causing hypoxia, leading to both heart failures as well as myocardial infarction. If you actually look at all these mechanisms, bradykinin release, then pro-inflammatory cytokines, direct myocardial infection, myocarditis can occur, and then they have numerous other cytokines and vasoactive factors being produced. You have three end results on the heart. One, of course, myocardial infarction, which we've explained how it happens. We then have myocarditis leading to heart failure, which is the direct infection on the myocardium. And then, of course, all this can also lead to arrhythmias because of myocarditis, cytokines, pro-inflammatory reaction. So three major things happen. And both these representative studies will actually tell you that about various, and there are numerous drugs, by the way, being tested for treating COVID as of March 16th of 2020. And here's this list of drugs, and here's another list of drugs, which is looking at every aspect. So if you actually say, what are the cardiovascular complications? Acute myocardial infarction occur and that goes for trop T rises, acute coronary syndrome in approximately 7% of the patients. Myocarditis, which is exacerbation, includes exacerbation of heart failure and shock. Many of these patients present as pseudo-MIs with an ST elevation pattern across all the leads globally with troponin rises, and this myocarditis is mistaken in some instances for acute myocardial infarction. That has been well documented. Just want to dwell a bit on this. In the West, apart from the anesthetist and the critical care, the cardiologists have been the greatest workforce which has suffered from COVID positivity and the test becoming positive. And that the reason for that has been that the myocarditis, many of these present and get mistaken for acute MI. In fact, they've been taken to have a primary angioplasty done to the cath lab, only later to discover normal coronary arteries, and then subsequently a COVID test which gets positive. A similar story to that happened in Wokhar, except that patient presented with acute myocardial infarction and a primary. But pseudo-MIs has been one of the common presentations of COVID-19 disease, resulting in infections to cardiologists. Arrhythmias are 16%, and that's one of the reasons for the admissions into ICUs. So you can see nearly 10 to 12% of the patients who have COVID-19 disease have severe cardiac problems, resulting in admissions to the ICU for cardiac rather than pulmonary causes. So we have LV dysfunction, we have heart failure, we have cardiomyocarditis leading to shock, we have tachycardia, bradycardias, we have ventricular fibrillations, atrial fibrillations, and we have sudden cardiac death. Of course, coronary artery disease, we mentioned that the systemic inflammation leads to plaque rupture. In fact, patients who had previous stent and on a single antiplatelet, if they get COVID positivity, can actually have an pro-inflammatory stage leading to stent thrombosis. And here is where there is a ramp up of antiplatelet therapy to dual antiplatelet therapy in those who've had previous stents and are on a single antiplatelet therapy. So these patients, if they develop acute coronary syndromes, clearly the guidelines are the same way as manage all coronary syndromes. We have aspirins, we have statins, we have intensified antiplatelet regimens, including dual antiplatelet therapy. For heart failure arrhythmias, it is as per protocol as we handle heart failure and arrhythmias even at this time. And the increased systemic inflammatory response and procoagulant activity, must remember, even when the virus load goes away, even when a patient recovers from COVID, this systemic inflammatory activity takes some time to die down. So the body remains systemically inflamed with a procoagulant activity, which may take many months after the infection has gone away, and therefore one has to be cautious. And that practically explains what Dr. Agarwal had raised, that the patient from Italy had recovered. And then, lo and behold, when he's actually out in the community, a few days later, he actually has a myocardial infarction and dies from arrhythmia, and that is what it is. This has been noticed before with other SARS infections. A word about these management of heart failures and for those of the patients of diabetes and hypertension, for ACE inhibitors and ARB. As you know, these are drugs both used in diabetics for improving their outcomes, in previous coronary artery disease and hypertension, both, as well as in patients with heart failure. And therefore, it remains one of the first-line agents. You've heard this news earlier, and concern about use of ACE inhibitors and ARBs in severe COVID disease. There was a paper which suggested this, and this paper actually was related to animal experiments and looking at ACE2 receptors. What happens, let me tell you the hypothesis to make you understand, and there were a couple of papers related to this, but the paper was not related, I must say, to a clinical use of the drug or actually seeing any observations in humans who were actually taking the drug. It was just a hypothesis out of animal experiments. And this was a hypothesis that those who are on long-term ACE inhibitors or ARB, and ACE2 inhibitors exist in both cardiac muscle as well as pulmonary, they have an upregulation of the ACE2. The ACE2 receptor actually increase in the heart and lungs in those who've been taking ACE inhibitors and ARB for a long duration of time. And the SARS-CoV-2 virus binds to the ACE2 receptors and in fact gains entry into the cells, into the target cells, by going through these ACE2 receptors and causes pulmonary disease. So it was thought, at least in animal experiments and in bench testing, that those who actually have ACE2 receptors increased will get a worse pulmonary, and those who take ACE2, ACE1 and ARBs have higher ACE2 receptors. But this evidence is clearly false. There is still no human data to suggest this. In fact, or based on those two animal data. But interestingly, I can also tell you, and everybody knows this, even on bench testing on science, that ACE2 receptors, while they get upregulated, can actually protect from severe inflammatory reaction. So in fact, if you go back to this text talks about, is there two aspects working it here? In some, ACE2 receptors and ACE inhibitors can be protective, and in others, it can be harmful. It's speculation and hypothesis. So the European cardiac societies of various of Europe as well as United States, the European Society of Cardiology, the ESC Council on Hypertension, the European Nephro Society, the American Heart Association, American College of Cardiology, and Heart Failure Society of America all came out with their advisories and guidance between 13th and 17th March related to those two very preliminary animal and bench testing data. And it clearly said that the speculation about safety in ACE receptor and ARBs have not got any sound scientific basis. There is evidence from animal studies that these medicines could even be protective against serious lung complications rather than be detrimental. And it strongly recommends that every patient who's on ARB ACE inhibitors should continue the usual antihypertensive therapy per se. So I think that actually should put you at peace in the present times in management of these patients. Let me talk about what Dr. Agarwal had mentioned about cath lab practices for ST elevation myocardial infarction during these COVID times. You can understand that that's become even more important as of yesterday, because in Wokhart in Mumbai, it was a patient who came in with acute MI 5 days ago who had a primary angioplasty as per protocol, and then 5 days later, develops fever and turns out to be COVID plus. He had no symptoms. He was asymptomatic. He had no pyrexia on admission, and he had no pulmonary problems. The ACC and Society of Cardiovascular Angiography and Intervention came out with certain guidance for United States on 17 March. We must remember, each country is in a different phase of infection at the moment. Europe and United States are in a phase where everyone walking on the street probably has COVID positivity. For CSI, for India, we still don't think we are in that phase. We must remember that there are other logistic issues. With a lockdown, patient delays will happen. We do not have readily available rapid testing protocols. In fact, we don't have protocols available for an asymptomatic individual who's got no history of travel and no history of contact to even have testing. Troponin is not diagnostic, and neither can occur, by the way, in these cases, myocarditis, which presents an ST elevation. Is there a problem? KK, I just hear sounds. Is everything?
No, it's okay. Go ahead.
Okay. The troponin also cannot be diagnostic in these patients because these patients have myocarditis and can present with ST elevation and can be pseudo MIs. We must remember that PPE and even N95 masks are in short supply across the country. And when we talk about some policies and guidance, we're talking about not the highest level of centers. We're talking about how do we treat these patients across the country. And we have to for each center, evaluate the infection spread versus a benefit. For example, if it's only a COVID hospital and only treating COVID patients, and a primary and acute MI goes into that, then it's easy. He can easily, everybody is in their PPE suits, everybody is geared up to actually preventing infection. Also, all the patients are anyway COVID positive, and such a patient can have primary PCI. But if it's a non-COVID center, you can imagine the disruptions and the scare, not just the scare, the reality of an infection spread would lead to a cluster forming and a closure of the hospital, even if one personnel was to get infected. We also have to remember that these can differ from center to center, from region to region, place to place. But in general, most of our Indian hospitals would fit in, and that's why the CSI brought out a document, and in fact, which is actually about to be published, and it's already closed. A fast-track document, finished in 5 days to be published. What is essential as a strategy for MI is that international history of international travel is mandated. We must note that down. We must document it and get it signed both by the patient and the treating doctor. History of contact and fever or respiratory system problem. If this is triaged as a first thing in the triage itself, as a patient comes in with acute MI, in the triage itself, one has to decide about whether this is a confirmed COVID patient, which is a known COVID positive having an MI. And while we are seeing a rarity of this at the moment, you never know what lies 2 weeks ahead, where we may see more COVID positive patients come in with acute MIs. There could be a suspected COVID-19 patient. He's not got a testing done till now, but he's got an international travel, or the patient could have had a first degree contact of a patient who's had an known COVID positive patient. Again, could have had MI, or could be presenting with ST segment elevation pattern. These are patients who can land up at any hospital, and our preference would be thrombolysis and not primary PCI in these patients for the reasons we've explained earlier. But if we got to use thrombolysis and we have TPA available to us, it should be TPA. Of course, we can't generalize these for small hospitals, small district general hospitals, which have streptokinase available to them. But actually, thrombolysis would be the first choice in most of our centers with TPA where it is available. Now, we must also keep in mind that we know that myocarditis exists, can happen, and our suspicions have to be known to understand that is this myocarditis or is this actually an acute MI, and not to thrombolize unnecessarily patients for acute MI. So our threshold has to understand that we've got to use our clinical sense and judgment, because myocarditis presents like that. And finally, I've also got to tell you that those who have low probability or no COVID, which is like the patient who came in at Wockhardt a few days ago. No history, nothing, no symptoms, no fever, no chest, no contact history. We still believe, though this may change day after day, as the community spread, we start understanding how much community spread there is, or how many clusters have led to a community spread. And the low probability at the moment, which was with Wockhardt, may start becoming high probability for thrombolysis rather than primary PCI. But till today, I must say that we are treating these patients with primary PCI who have no probability of COVID or low probability of COVID, taking usual precautions and making sure that we stabilize, making sure that there are less people in the cath lab, that we actually do use a separated cath lab for these, and we actually make sure that we triage them very accurately. But we actually want to avoid it, and maybe in the next few days we may change our practices as we start knowing how much community spread there is. So these guidelines will have to change day after day after day, especially for India, and the next 2 weeks are going to be vital in many of these. For non-ST elevation myocardial infarction, be very clear. We stabilize these patients. We actually put them on medication. We make sure that they're stable enough. And if they are, then we can actually send them home. We may do an exercise test on them or a stress echo on them. And I'm actually talking about those patients who are not COVID positive and are stable. We would then actually send them home to bring them when everything is died down for an angiogram or PCI. So stabilization is our protocol for most of the patients who do not need an urgent or a semi-urgent angiogram. Those with strongly positive tests or those who have angina would actually be subjected to angiogram at the same sitting, in the same admission. We want to not load up our cath lab services and our ICU services to actually make them available for the possible influx of patients, which we hope do not happen over the coming weeks. And we want to protect ourselves well, make sure that we protect ourselves well. We are the front healthcare givers and providers. We actually have to be protected at every step in appropriate manner. N95, I believe we should all be wearing as front level people who taking care of whether COVID positive or not COVID positive, because like earlier had been said, now we gradually got to start assuming that every patient could be actually a COVID patient. So yes, as frontline workers, I'm very clear that we should be wearing N95 masks, looking after our patients. And what is very clear to me is that PPEs are going to be needed for COVID positive or COVID the second group of probable or suspected COVID-19 patients. Now, I think I have, how much time do I have?
3 minutes.
3 minutes. Then let me just tell you a case. I mean, it's always very illustrative. Okay, I'll go over this very rapidly. 64-year-old lady. Now we're starting to see cases coming from all over as teaching cases to us. By the way, till now, I don't think that this case, which was a primary PCI, and a couple of other cases are the only few cases, COVID positive cases, which have actually had treatment for coronary artery disease. 64-year-old, but this is what happens. Chest pain persistent for 2 days, no fever, no chills, no cough, afebrile. This is in New York. 130/80 blood pressure, 98 per minute, heart rate, oxygen saturation 100%. This is how she comes in. And her ECG is documented to have ST elevation myocardial infarction. Or she's diagnosed to have ST segment myocardial infarction. And she's taken to the cath lab. Her trops are high. Her angiogram shows normal coronary arteries. So what did she have? She had myocarditis. And immediately soon after, she actually goes into cardiogenic shock with pressures of 80/40. And IABP is put in the cath lab. Now you can imagine how many people would have got infected by this. IABP is happening, resuscitation happening. A transthoracic echo shows ejection fraction 30% with right-sided. RV is hypokinetic with a small pericardial effusion. Now it starts downing on people. The chest X-ray is clear, no infection. Now it starts downing on people. This could be myocarditis related to COVID. And then she has a treatment with hydroxychloroquine protocol, gradual improvement, decrease in lactates, improved in cardiac index. IABP was weaned off in 7 days. Echo at 10 days was ejection fraction 50%. And she went home after that and she was COVID positive. This is how they're going to present to us. This is going to be an eye-opener. It's going to be very revealing. Every case could be a COVID case. No symptom, no history, nothing, and yet presents as myocarditis. So, final slide. A lot has been said about use of hydroxychloroquine causing sudden cardiac death. A report of a doctor in Assam, a report of a couple in Phoenix, Arizona. You keep hearing this every day. Something or the other comes up. And there have been, of course, clear advice from the government as to who should have hydroxychloroquine. I would maintain those advisories by the ICMR. I just have to guide as to what important thing is for even those who are to be given as per ICMR advisories. The Indian Heart Rhythm Society has just come out with the guidelines as to how to give hydroxychloroquine in those patients on whom it is indicated through ICMR guidelines and prescribed by a doctor. It's actually in press at the moment and you will see it. And that's why I'm able to present this chart by the Heart Rhythm Society of India, that those, firstly, the combination of azithromycin and hydroxychloroquine both prolong QT interval and therefore is more dangerous than hydroxychloroquine alone. And if the QT interval is normal, which is 450 in males and 460 in females, 460 to 70 in females, hydroxychloroquine can be given with no further risk stratification. In group B, where the QTC interval is between 460 and 500, one has to make sure that there's no dyselectrolemia, no hypokalemia, no calcemia. One has to make sure that there are no other drugs like codron, etc., prolonging QT interval. And then, of course, it can be given. And then those who got greater than 500 milliseconds, one has to make sure that if this is a low COVID-19 risk, then HCQ should not be given and avoided. It's only considered in those with extreme high risk, which also includes patients who have got to be treated for COVID-positive serious pulmonary infections. I think this would be my last slide. If there are any questions, I'll take it, but I think I've comprehensively tried to cover the present state of knowledge of COVID-19 infections resulting in cardiovascular disease and its sequelae. Thank you very much for your attention.
Thank you, Dr. Seth, for talking about it. Let me summarize that QTC, if normal, hydroxychloroquine is normal, you will start getting cases in cardiology which are, and any unexplained case today will be a COVID positive unless proved otherwise. I had a 60-year-old lady day before yesterday suddenly presented and died in 24 hours, and she had a viral bilateral pneumonia. And I also noticed that her right-sided RA-RV was involved. Maybe we are missing something in terms of why specifically RV is involved in such cases. Regarding cath lab, very well said, thrombolysis will come back in this COVID era. And let's go back with a message. Every patient in the hospital is COVID positive unless proved otherwise. And as far as possible, all cardiologists and doctors should wear N95 mask. Thank you, Professor Dr. Ashok Seth, Chairman, Fortis Escort Heart Institute, New Delhi. Thank you, Veer.
Thank you. Thank you, Dr. K. Agarwal. Thank you very much.